today's host. To introduce Ms. Neskey, aka the Posh PA, is a practicing hematology oncology physician associate, PA counselor, and wellness advocate. She graduated from Yale's PA program in 2005 and started out in hospitalist medicine before transitioning to hematology oncology in 2007. Ms. Neskey created the Posh PA to help guide, educate, inspire, and encourage aspiring PAs, as well as to promote wellness and build confidence. I'm glad that you're on here today, Ms. Neskey. A couple of reminders before we begin. We encourage you to turn on your cameras if you're able to. This session will be recorded and uploaded to our YouTube channel. Also, there will be a Q&A at the end of the session, and you can unmute at that time, or you can feel free to write in your questions at the chat at any time, and we'll cover them during the Q&A at the very end. So that's everything covered. And with that said, Ms. Neskey, feel free to take it away.
I feel so old, Miss Neskey. Okay, I am Michele Neskey. Thank you for that wonderful introduction, Michael. That was amazing. And thank you for some of you for putting your screens on. I love to see faces. So thank you for that. I don't care if you're in your car or in the bathroom. I like to see faces. So as Michael said, I graduated from the Yale PA program in 2005. I have worked in a few different specialties, ultimately landed in oncology. I've been there for the last 14 years doing adult medical oncology. And so that's what you will see today. I primarily take care of lung cancer patients in the outpatient setting. I have worked in different oncology settings throughout my career, just to give you a little background. Oh, more faces. Just to give you a little more background, my first job after graduation from PA school was in internal medicine. I worked as a hospitalist PA and got great experience there as a new graduate. And then my husband, who, he wasn't my husband quite yet, but he was my fiance. We moved to Miami. We got married actually, and then moved to Miami, and he did his residency in ENT for 5 years. So we were in Miami, and the first year I was in Miami, I worked in hepatology, which is more of a GI specialty, and then found my first job in community oncology practice in Miami Beach. And I was there for 4 years, and I absolutely loved it. From there, we moved to Texas, and I got a job at MD Anderson Cancer Center, doing thoracic and mostly head and neck medical oncology. So very specialized, huge cancer centers, a big difference from what I was doing before in community oncology, where I was doing kind of a little of everything, inpatient, outpatient, heme, onc, everything, to very highly specialized place. Did a little inpatient there, mostly outpatient, but had a managerial role as a PA. I was a supervisor of about 14 nurse practitioners and PAs. And then we moved to Charleston 7 years ago. So I'm in South Carolina currently. We've been here, like I said, 7 years, and I've been doing just outpatient adult medical oncology and pretty much every solid tumor you could think of: lung, breast, colon, GU, whatever, but primarily spent my time in lung cancer. So that's a little bit about my background and how I got here. And I can answer any questions you have about, PAs moving from state to state, what that looks like, or changing specialties, or what you need to do there, which is essentially nothing, just get a job. But basically today I'm going to take you through what my day-to-day is, and give you a little bit of a sense of what a typical patient looks like for me. I had a really interesting patient this week that I didn't get time to change my PowerPoint, but I can talk a little bit about as well. So I will share my screen. If I look this way, it's because I have two screens and my slide is over here. I love these faces. Thank you everybody for being here. Okay, hold up. Let me do my screen here. Present. Okay. Share screen. Here we go. I have a little video and I hope that it works. Okay. So, as I said, I am outpatient medical oncology. So I see a template of patients between 8:30 and 5 p.m. A template just means a schedule, and it's the way the patients are slotted throughout the day. So I have 20-minute appointments for follow-up appointments, and anything bigger than that is a little bit longer appointment. So every 20 minutes, I see a patient. Obviously, sometimes it takes longer, sometimes it takes less, but that's basically the way the template is laid out from 8:30 to 5. I do see new patients. The attending oncologist usually comes in to see those patients, but I'm comfortable seeing new patients and can do that for them. I also manage infusion reactions. So I take care of patients who all get treatment of some type for cancer, like chemotherapy, Opdivo, Keytruda, these things you see on TV that are like IV medications or even oral medications. Most of my patients have stage 4 cancer. Some of them have earlier stage cancers that are being treated with preventative measures with chemotherapy or some of these other treatments. But mostly my patients have metastatic cancer and are being treated with some kind of treatment that goes through their whole body to treat the cancer cells we can see and the cancer cells we can't see. So infusion reactions just means they go over into our infusion center. So you'll see a little bit here, but like I have an office, where we see patient rooms, and then across the way is where the patients actually get their IV treatments. It's an outpatient center, and then they go home. So sometimes patients get allergic reactions to these things, and I have to manage those as well. I see people going under therapy, but I also see people who are on surveillance. So we treated them for their cancer, and now we're just following them. An independent template means I have my own schedule of patients. The physician have their own schedule of patients, and I have my own schedule of patients. We share nursing support sometimes, but for the most part, I practice pretty independently of my physicians. There's actually one day a week where I have no physicians there. So, I'm pretty much there doing my own thing, even if they are there, and I can ask questions as needed. So a day with me, 5:30 to 6 o'clock. So this is actually not summertime but like when school starts for me and my daughter next week, I'm back to getting up at 5:30, which is going to be trouble because in the summer, I do not have to get up that early, but usually get up by 6 o'clock. I get my workout in, and then from 6:30 to 7:30, I get ready. I take her to school, and then I get to work. First patient is scheduled at 8:30. My last patient is usually scheduled at 4:30. I have to do documentation, all the things. So I usually don't get out of there till 5:30 or 6. Okay, let's see if this works. Here we go.
Hey guys.
Can you hear it?
I'm doing a brief tour of my office.
So this is a tour of my office.
Okay, normal patient room. There we go. This is the patient's hallway. And then we walk out into the provider workspace, which is here. So basically I see patients in here that are on therapy, and I review, there's a computer in the room, so I review scans with them. And we go over everything they need. I treat their side effects and everything like that. So that's just a basic overview of my office, since you can't be here with me in person. Okay, now I'll take you right across the hallway to where our patients get treated in the infusion center. Right here, here we go. So I can't flip this video.
Mama, what is
Two
going
typical
on?
reasons. I'm not just way for us.
Why? Mama, Marcus.
Sorry, hold on one second.
Marcus.
Okay, that was my brief overview. Sorry, I have to say goodnight to my kid. Mwah, love you. See you. Okay, so that is a basic overview of my office. So you can see where my clinic space is, and then we walk directly across the hall and everybody's there. So the way this works, go back, is a patient arrives to the cancer center. They come in the morning, they check in, they go directly to the lab. They have their blood drawn, or if they have a port, which is a small device that goes under the skin for access to the vein, they go to the port room. They get their labs drawn, and they get their vital signs taken, and then they get put in a clinic room. I see them, or the doctor sees them, whoever's there. And then we send them to their treatment or for any additional testing that they might need. So that's the typical clinic flow. My role is to really assess their symptoms, manage prescribed medications, adjust dosages, provide a lot of education on their disease, on their treatment, what to expect from the results of their treatment and their imaging. So like if giving a patient chemotherapy for their lung cancer, what they should expect to see on their first set of scans to sort of manage those expectations. You know, if we're going to continue their treatment, if we're going to make a change. I provide a lot of education and teaching on all these drugs, like all these anti-cancer drugs, side effects. I consent patients for treatment. I create their treatment plan. I sign them as needed. I'm always communicating with the nurses in both my clinic and in the infusion center. I manage any electrolyte abnormalities, any emergencies that come in, and I send patients for additional testing. So for example, I had a patient come in the other day who had severe pain in her neck and shoulder, raining down the arm. And I sent her for an emergent MRI to see what was going on there. So just sort of things like that that come in as well. So this is sort of a little bit of an atypical patient, but she is now 30. She's a 30-year-old woman who had absolutely no medical history, who presented with cough and wheezing to her primary doctor. You would treat common things as common. So she got antibiotics and prednisone and all the things. So steroids, inhalers, antibiotics, and her symptoms, though, did not get better. They actually gradually worsened. And then she started getting a lot of chest pain. No cancer history, no history of smoking. She initially had a biopsy of a breast nodule, which was negative for cancer. And she's adopted, so she doesn't know her full family history, but said her maternal grandmother did have breast cancer. Her mother may have had cancer, but didn't know what kind. She had a CAT scan of her chest, CT scan of her chest, which showed basically abrupt termination of the right upper lobe bronchus with complete right upper lobe collapse. What that means is you basically have a trachea that splits off into two main bronchuses, one in your right lung, one in your left lung. And on the right side, it was basically blocked off, and the top portion of her lung was collapsed from a tumor. And she had other small nodules in her lungs, so other small, round, solid tumors in both lungs, as well as lymph nodes in the center portion of her chest, which were very suspicious for a mass or for cancer. So when you have when you have a tumor, when you have a cancer, the first place that it drains is into your lymph nodes, right? Because your immune system is your first line of defense against any cancer, against any infection, against anything foreign in your body. And so your lymph nodes get enlarged because either they've been taken over by cancer cells or they're trying to fight it. So they can be enlarged and inflamed. So she had a bronchoscopy, which is a procedure where they go down through your nose. Usually a pulmonologist, lung specialist will go down through your nose, take what they call an endobronchial ultrasound. So they'll put it down into your trachea, and they'll look with a little ultrasound probe. And if they see a spot, they'll put a needle through the bronchus and biopsy it. And that was positive for adenocarcinoma, which is the most common type of lung cancer in never smokers. The rest of her CT scans, abdomen and pelvis, showed she had this small thing in her liver, which was benign, and then something else in her hip, which also kind of looked benign. A PET scan is a specialized nuclear medicine scan where you get an injectable dye that is sugar-based. It's not iodine. And any cells that are metabolically active will light up yellow like a light bulb on the PET scan, and it covers your skull base to your mid-thigh. It's not good for assessing the brain because that's always metabolically active. It's also not good. So anything that's metabolically active, heart, kidneys, bladder, brain, will always light up yellow. It's other areas that you're looking for. And it showed a big mass with collapse of her right upper lung, lymph nodes in her neck and chest, and just kind of cancer spots throughout her entire chest, as well as her cervical spine at C7. So your seventh vertebrae in your cervical spine. The thing on her thyroid was actually a separate issue. This was not related to her lung cancer. So when I say light up yellow, this is what I mean. So this big area of yellow here on the right is basically her primary tumor. So if you orient yourself to this, you're laying flat from head to toe, and there's slices going down you horizontally. This is your right, left. This is your right shoulder, left shoulder. This is your spine. This is the anterior chest. And then scapula, scapula. This is your main trachea. This is the aorta. This should not be here. You see how this is all nice and clear? This should not be here. So that's cancer. And along the coronal cuts, you can see really where the cancer lies, sort of way up here at the top. So staging of cancer, almost all cancers are staged in the TNM system, tumor node metastasis. It's different for every cancer. It changes all the time. You always have to have something in your pocket or looking it up, but you want to see tumor size, lymph node status, and metastasis, and that will give you your overall stage. For her, it's easy. It's a stage 4 because the cancer has spread outside its primary site, and she has it in both lungs as well as a bone. Immediately when it spreads outside the lung, it's stage 4. And so there's different, like I said, there's different staging systems for every cancer, and not every stage 4 cancer is incurable. So it's important to know each cancer has its own staging and different prognoses. So she actually got radiation to the big tumor that you just saw, because radiation sends electron beam into that area and sort of, for lack of better word, sort of microwaves it and kind of heats it out from the inside. But what it will do is shrink the tumor and open her airway. So she stopped coughing quite quickly. And then we sent her tumor specimen for what we call KRAS testing or molecular testing. And the reason why we do this is because there are certain people who are never or light smokers. So probably about 15 to 20% of people who get lung cancer have never smoked in their life. And those people have a very high chance of having this mutation in their tumor, this genetic mutation that causes the cancer to grow. And those are known as EGFR, the epidermal growth factor receptor, and ALK fusion or a ROS rearrangement. And the reason why those are important is because if your tumor has one of those markers and it's positive, you can be treated with a pill instead of an IV medication. So we test everybody for this because it has a different prognosis, and it also carries an option to be treated with pills instead of IV therapies. PD-L1 score is just a protein that's expressed on tumor cells or on your normal cells. And we want to see that is a predictor of how well you may respond to immunotherapy, which are these newer drugs you may see on television. She was negative for all of those things, which is somewhat unusual in a never smoker young woman. You might expect to have at least a, 15 to 20% chance of having one of these mutations, and she did not. So we wound up having to start IV treatments with chemotherapy and immunotherapy. So just so you know, chemotherapy, everybody knows somebody who went through chemotherapy, or horror stories about somebody who went through chemotherapy, or just someone in their family, friend, whatever. Chemotherapy works by damaging the DNA of cancer cells in one way or the other. So they all have different mechanisms. Some stop the cell cycle, some attack microtubules, some are taxanes, some are metabolite inhibitors. They all work differently, but the ultimate goal is they're cytotoxic. They're meant to kill cells, right? Kill cancer cells. And for years, that's where therapies were being directed. How can we kill these cancer cells? How can we attack the cancer cells? And cancer, by definition, cancer cells are cells that don't die. They're able to invade. They're able to move through tissues, unlike other cells, because they're mutated in one way or the other. They've lost their tumor suppressor or basically oncogenic drivers. So our bodies have checks and balances, right? So every day you could have a cancer cell come up, but your body has, tumor suppressor genes that are supposed to go attack that, or, different areas that are supposed to be in check. And when one of those mutates and is out of balance, then you get cancer cells that can grow, divide, spread, invade, and do all of the bad things that we know that cancer can do. So for years, the treatment for cancer was kill cancer cells, kill cancer cells. How can we kill cancer cells? The difference is immunotherapy and Opdivo, Keytruda, the things you see on TV, the ones the President Carter got, all the things, those drugs work completely differently. They are focusing on training your immune system to fight the cancer. So like when you get an infection, like when you get a cut, like when you get anything that is damage to your body, your immune system is your first line of defense, and it's going to go and try to attack this thing, right? So you get a cancer cell in your body, your immune cells are going to go, no, you're abnormal, bye, and kill it, right? Well, over time, because cancer cells don't die and they replicate fast and they spread, they actually tire out your immune system and they actually turn it off. So in very simple, this is very, very detailed. I'm making it very simple, but basically when your immune cell attaches to a cancer cell, it turns your immune system off. And so what these drugs are doing is blocking that connection so that your immune system works to fight the cancer. So it's trying to train your own immune system and your body, or retrain it to fight the cancer rather than focusing on the cancer cell itself. And that's why it's such a big deal in the cancer field, and why these drugs have been so popular over the past couple of years, is because it's just a completely different way of treating cancer. And when you combine these things together, what you're getting is a lot of cell death, a lot of inflammation, and then you're getting a revved up immune system that's just eating the crap out of these cancers at this point, right? So sometimes the response is just much more robust, and patients' tumors are shrinking and they're feeling better and things like that. So that's just a little background about that. So for this person on treatment, her very first treatment day, paged to the infusion suite 2 minutes after she received an IV nausea medicine. She got chest tightness. She got completely red. Her oxygen level dropped to 85. Her blood pressure went up to 160. So we gave her Benadryl and steroids and all the things that we give when a patient has an infusion reaction. She started to recover pretty quickly. So without doing anything else, we held her infusion for a while. She just saturates again. So her oxygen level drops again, and more steroids and more oxygen and all the things. After about an hour, she stabilized. We decided to give her the chemotherapy and not her immunotherapy. Why? So number one is she didn't react to a chemotherapy drug. She actually reacted to a nausea drug, which is very unusual. And we don't usually see infusion reactions to nausea medicines. But what we figured out with the pharmacists and everybody was that the nausea medicine had a solvent in it that she was likely allergic to, and the immunotherapy that she was supposed to get had that same solvent, but the chemo did not. So we went on and gave her the chemo, and she had no issues, but we didn't give her the other drug because we were worried about having that cross reaction to the solvent that the drug was mixed in. So a lot of things come to play in the situation. 2 weeks later, she does fine. 2 weeks later, she comes for follow-up. She can't swallow. She can't take any liquids. She's losing weight. She has no patches on the back of her throat, no infections, no fever. She's having some pain when she pees. And then randomly she has itching of like her right ear, and she's tired. So when I examine her, she's got very red posterior pharynx, which is a fancy word for throat. And then she had no thrush, so she had no fungal infection. So because patients who get these treatments can have low immune systems, sometimes you think they'll get thrush. There's just a fungal infection. She didn't have it. She did have redness in her right ear canal, but her eardrum looked fine. The rest of her exam was normal. Her urine sample, though, looked a little bit like she might have an infection. So a lot of things going on here. So what does Michele do? So the swallowing issue is secondary to the radiation that she had. So radiation therapy to your lung, especially way up here, is very close to other organs, including your esophagus. And so very oftentimes when patients get difficulty swallowing after radiation, it's because there's an inflammation of the esophagus. So I notified her radiation doctor. I prescribed her a medication that coats the esophagus and numbs it so that she can get some food down. I also gave her some fluids in the infusion center. She needs to be eating and drinking liquids, soft solids at this point. And then on top of it, a completely separate issue, she's got an ear infection, an outer ear infection, and a urinary tract infection, which are unrelated to the cancer, but basically she has all of these things going on. And I just do this to point out that not everything is a side effect of treatment. There are other things that walk in with your cancer patient that you have to be ready to treat. So there's a lot of internal medicine going on when you're treating oncology patients as well. So esophagitis is an inflammation of the esophagus after radiation to the chest. It can be made worse by chemotherapy. It feels like food gets stuck there. The way you treat this is with antacid pain medications and time. That's really all that makes it go away. You have to give IV fluids. If they're not taking any nutrition, you have to do a feeding tube. Usually you don't have to do that, but it happens. It usually peaks 2 weeks after radiation and improves by 4 weeks after. So the takeaways here from this particular case is that cancer care is multidisciplinary and it requires constant communication between radiation oncology, surgical oncology, medical oncology, as well as nursing in the infusion center, wherever your patient is getting treated. You need to think critically when patients present with these symptoms, because what one of my roles is that I really try to keep patients out of the hospital, if at all possible. So doing things and helping them to try to get better, or just being accessible to them when they're not feeling well. And I'm like, okay, come in today, I'll see you, is one of the ways I can help do that. At the end of the day, I make sure my attending knows any major changes in the care of their patient. And education and teaching is a very large component of my job, including managing expectations, having end of life discussions, advocacy, and symptom management. So those are sort of the main takeaways. And I just wanted to kind of share with you a separate case that I had this week. And I mentioned a little bit earlier, was a 39-year-old woman with metastatic breast cancer. And we've been seeing her very regularly. And she came in this week and she literally was hunched over and, couldn't move her arm. And she was having some numbness in her hand and severe pain. And I tried to get her an outpatient MRI at every single location that we possibly had, and we couldn't get her in. I wound up having to send her to the emergency room because I was worried that she might have spinal cord compression, which is an oncology emergency. There is a certain set of oncology emergencies. And if you have cancer that spreads to the spine and you start getting neurological changes and pain, you can lose function of your arm within 24 hours or your legs within 24 hours. So it's an actual emergency. And, getting these people to the ER, appropriate care, seeing what's going on is really important. So the reason why I like oncology is because, for a number of reasons, but one of the reasons is because there's a lot of internal medicine involved. So I'm always on my toes, managing different things, electrolyte problems, UTIs, things like that. But then also it's the frequency in which I see patients and really get to develop a nice relationship with them. I get to kind of see them through this process, get to know about them, get to learn about their families, and really know them as people, but also, as patients. And so There's a lot of different things I do. That's the clinical part of my job. I also have a managerial portion of my job where I serve as a manager for the health system, for advanced practice providers, professional development and wellness. So that's another aspect. And so, yeah, so that's basically my, my presentation and my day-to-day. And I'd love to take questions from you all on anything that I've said. I know I talked a lot, but anything I've said, anything you want to know about becoming a PA, any of those things, I'm happy to take those questions.
Sounds good. Thank you so much for your presentation. Usually we have questions in the chat, but we'll wait on our audience to write in their questions in the chat. Meanwhile, I have a question.
Sure.
Maybe I can ask you. So maybe someone here might be listening in and they're on the fence between being a PA, doctor, maybe nurse practitioner. What are the kind of dividing borders that you see between those fields that might make their decision easier to proceed forward with?
Yeah, so it's not an easy decision. Okay, so first I want to say that if you're waffling, it's okay. And I think, I waffled as well. So somebody asked, what was my path to PA? And I didn't know in college that I wanted to go into medicine. I knew that I wanted to do something in science. I knew that I didn't want to do certain other things. And I majored in genetics, and I worked in, ironically, a lung cancer research lab doing basic science research. And so I was there about 1.5 years, and I thought to myself, oh, this is not for me. I'm not very good at this job. I don't particularly think this is like what I'm supposed to do for the rest of my life. What are my options? And so the immediate option to me was a PhD, because that's kind of the route I was on. And I thought, well, what am I going to do with a PhD? I don't really want to be in, a research lab. And I was not, really interested in that at that time in doing more, PhD related research. And so that really moved me away. And then what happened was the physician that I was working for in the lab, I asked him if I could go to the clinic with him just to see that side, of it. And so I spent a day with him there, and I'm not joking. I was there for like 2 hours, and I was like, okay, I am clearly on the wrong side of medicine. This is way more my jam.
I listen to music.
But now I'm 23 years old or 22 years old, and I'm not really sure how I can do this. And so for me, it was just a little bit different, because I was like, well, I either go to medical school or, I find something else. And so I looked into nurse practitioner and nursing, and I never wanted to be a nurse. And I love nurses. I love the nurse practitioners I work with. I really value and trust and respect nurses to the highest level. But the way that nurses learn and are trained was not something that I could identify with. I felt that I wanted something that was more in line with how a doctor was trained. So for me, it was doctor or what, right? Like I didn't even know about PA at that point. And one of my family, my mom's, well, I grew up with her. One of our family friends growing up, their daughter was a PA, and they said, why don't you talk to her? Why don't you see what that's like? Why don't you see what that means? And I talked to her, and I spent time, and I researched it, and I said, well, I think this could be the perfect fit. I was never somebody that wanted to be a doctor. And for some reason, I just feel that if you're somebody that's like, medicine is all you've thought about, and being a doctor is something that you've really wanted, and you can't see yourself doing something else, and in your gut that you want to be the end of the line. You want to be that person that carries that responsibility, carries that decision making, has that sort of autonomy, is the end of the line when it comes to patient decision making and care. then you should be a doctor, because if you're going to regret not being a doctor, you should never be a PA or an NP or any of those other things. My husband is a doctor. He said, I just never thought about anything else because I wanted to be the end of the line. And then he said, also, my ego was too big, but that's just him. He's a surgeon, right? So I think that it has a lot to do with autonomy, high level decision-making, where you see you want your career going. Do you want to specialize in one thing and be the expert? Okay, so that's the biggest difference between being outside of the years of training, obviously, of being a doctor, is that you do a lot more years of training and you do one specialty and you do that specialty and you're an expert. Whereas being a PA, yes, you do less training, you're trained in a very similar model, but you have the ability to move around. And you have the ability to say, I'm going to work in internal medicine for a year, and then I'm going to go do this. Or my kids, I have 3 kids under the age of 3. I'm going to go work in urgent care 3 days a week and call it a day. Or, and you have that ability to move. So it's just different. Being a doctor and being a PA is different. Being a nurse practitioner and being a PA is where it gets a little harder, right? Because the biggest difference is nurses are trained in a nursing model and they are nurses first. So nurse practitioners are nurses first, whereas PAs can be anything, first. So most of us have over 2,000 to 5,000 hours of experience doing something else prior to going to PA school. So whether that's medical assisting, EMT, paramedics, all of those things, we all have those years of experience before we go to PA school. And that's, kind of why the training is less, but we can come from a lot of different backgrounds. Same thing goes from, goes into nursing. You can decide you want to change to nursing, but every nurse practitioner is a nurse first, and nurse practitioners have a focus. So they have sort of an umbrella. So it's not quite like physicians where you're just kind of drilled into that specialty, but it's not like PA either where you can jump around a ton. Nurse practitioners have a focus. So for example, you can be adult clinical care, critical care. So you have that umbrella of adult critical care, or you have that umbrella of pediatrics, but you can't be a family practice nurse practitioner and then go do adult critical care. You cannot do that. So there are some umbrellas in which you have to practice as a nurse practitioner. So that's the biggest difference. And also licensure for NPs is different. And nurses have been around for a very long time. They have a very large lobby. They do very well in the legislative space. So nurse practitioners in some states have a lot more autonomy than PAs do. But in general, that is very state-based. I do not experience that in particular. But there are certain states where NPs have more autonomy, for example, to open a practice or something like that. And there are certain specialties that are more nurse practitioner dominant, like OB, because midwives, certified nurse midwives can be NPs and things like that. But I would say the biggest difference between PA and NP is that focus, that umbrella, and then the way they are trained in that, nursing model, which is much more, sort of holistic, focused on the patient needs. And then the PA model is more medical trained like physicians are, but have the flexibility to sort of move between those specialties. And then being a doctor is sort of the next level. So, I hope that didn't confuse you too much, and it was a long-winded answer, but a very popular question. And so I'm glad you asked that. So I think I answered a lot of these questions with that.
Yeah, definitely. Thank you so much for the advice. I'm sure that all of us will definitely find it helpful, especially for those considering multiple careers in healthcare. I think you then covered, there was one other student who asked, what is the path you took to become a PA after college? I think you covered that. Anything else you want to add to that?
No, I mean, I just, I had to go back to school. I had to take some classes. I had to, the hard part about deciding a little bit later was that I had to kind of move in reverse. So I, was a college graduate with a job that had to go back to school and take additional classes and then get a certification as a Red Cross to work as a certified nurse assistant and a patient care tech on a bone marrow transplant for making minimum wage, like doing all these different things. So, your friends graduate from college, they're doing all these things, making money, doing the things. And you're like, hey, I'm over here working like minimum wage. And my parents are like, what are you doing? Like, what is the situation? So that is where you really have to be resolute about what you've decided to do, because people are just gonna be like, I don't know what you're doing. Like, why are you doing this? But ultimately, I was working towards a goal, and it was a very short period of time. And luckily I was, able to apply and be accepted and, get into school. So that's the end of that.
And you mentioned like with your case and a lot more details about your practice that it's very heavy on oncology. So it seems like it's more oncology based, right? And to tag along with that, what does your hematology work consist of?
So it's very interesting because it depends on your practice setting. So when I first started working in hemonc, I did community oncology. So it was all hematology, all oncology. So you could have leukemia, lymphoma, iron deficiency anemia, any of these different kinds of anemia, lung cancer, breast cancer, colon cancer. We saw it all. Like, we saw everything. And that's what it's like when you're in a community where you are sort of the first line of referral from primary doctors and things like that. Whereas moving into a tertiary cancer center like MD Anderson or where I am now, it's more specialized into oncology or hematology. So it separates. So it just depends where you practice. So like in my last two institutions, you either do solid tumor or you do liquid tumors. So you're either doing hematology, leukemia, lymphoma, bone marrow transplant, stem cell transplant, or you're doing breast cancer, colon cancer, melanoma, that kind of, so they're very separate. But if you're in a community practice, you could see anything. So my hematology experience now is I do a lot of anemia, a lot of thrombocytopenia, and a lot of febrile neutropenia. So we do that as side effects from our treatment. So we manage the hematological complications from the treatments that we're giving, and can diagnose people with certain anemias and vitamin deficiency anemias and things like that.
Sounds good. And one person asked a pretty interesting question about working internationally as a PA. They looked into some countries that would allow that, and obviously it would be dependent by each country.
Yes.
It's not going to be the same across, but having a PA education in the US, do you know of any PAs who have gone outside the US internationally and been still able to work maybe at more limited of a scope or even full scope?
Yeah, I mean, I know that Germany has PA. I know UK has PAs, but they function very differently. I know some people that have gone to more sort of not third world, but the countries that need medical care and are able to practice there with a greater scope, depending on what they're doing. But I don't know. It's very variable, on the laws and the scope of practice when you move to another country. So even Canada, it's very different to be trained as a PA in Canada. A lot of Canadian applicants will apply here and can practice in both ways. But I do not personally know PAs that practice outside and have been trained here and practice somewhere else outside of their, like if they've done so sort of global impact work and things like that.
Okay. And then also for the first patient A you mentioned, was the UTI and ear infection, was that a result of a weakened immune system?
No, her white count was totally normal. So her immune system was functioning normally. Those just happened to be things common things are common even in cancer patients. So, they happen, even when, patients get things, and she never got another one again. So even though her counts have gone lower. So, I think it wasn't at that point.
Okay. And then you went before through the difference and, what you would how you would approach the people who are, on the borderline
Yeah.
between being a PA and being a doctor. But for those who are more of being the borderline between a PA and NP, or a
Mhm.
PA and nurse, those other fields in healthcare, what would you say to them?
So for a PA and a PA and a nurse, like RN. So RNs do a lot of bedside nursing. They do a lot of a lot of the technical work that comes into patient care. So intake, IV lines, things like that. Being at the bedside, doing Foley catheters, being an inpatient, you could be outpatient. The difference between nurses like RNs and PAs or NPs is the level of decision making and the scope. So when you're a PA or an NP, like you're the one that is actually making the decision about, hey, let's give this patient this drug. Hey, let's not do that procedure. Let's think of this one. Hey, let's give the patient this. Let's do this. So that's the biggest difference between like NP, PA, and RN. As far as NP versus PA, I mean, it really depends on what your path has been thus far. So I know a ton of RNs who have gone to PA, and I know a ton of RNs that have gone into nurse practitioner. And so I think from an application standpoint, nurse practitioner programs are slightly more forgiving. The PA school application process is extremely competitive. And it's only gotten more competitive over the past couple of years because of the popularity of the profession, the press that the profession has gotten. And there are a lot of nurse practitioner programs that allow you to do sort of hybrid, like online, more learning portions and then go in clinically, whereas PA programs are more limited in that regard. There is a lot more. There's more of them coming now, in a hybrid setting, but that's a difference as well. So if you're locked into a certain area or you can't travel or something like that, it has a lot to do with your personal decisions as well as your professional goals, right? In day-to-day practice, I stand next to a nurse practitioner and we do very similar things. So once you're out of school and you're trained and you're doing the things, we work very similarly. But the difference is in sort of like legislative issues, practice-based sort of things, and the training, the way that you're trained, the way in which the schooling is structured. That is the biggest difference. And then, like I said, the focus. So like if you're adult critical care and you're an NP, you can work in different areas of critical care, but you got to stay in critical care. Whereas a PA, I could say, hey, I'm going to work in ICU, and then, oh, never mind, I'm going to go work in dermatology. And you don't have to get any additional training, and you can move outside that umbrella. Whereas nurse practitioners have to kind of stay in that umbrella. That's the biggest change.
The flexibility.
Yeah.
To go along with that, I was just also wondering, you mentioned the actual like kind of career differences, what you're going to be doing day in and day out. What about the application between a doctor, PA, and NP? How do those vary? Obviously, they're all in healthcare, but what are the main points that vary?
So the biggest points that vary between doctor and PA is like the MD application, MD DO application process. You have to take the MCAT. Obviously, you do not have to take that for PA school. The application cycle is pretty set. So it's, sort of one time a year. And I feel like the prerequisites for medical school and the things that schools required are much more standard. So they're sort of standardized across the board. So you can be like, okay, I'm going to apply to medical school. I need all of these requirements. This is what I need. This is what I should have. PA school, the hardest part about applying to PA school is the variation on prerequisites and what you need. That is the number one hardest part of this application process, and it gets worse every year. So it's like 10 schools require these prerequisites, but a few of them require these. Oh, and by the way, this school requires that standardized test. This school requires the GRE, but this one requires now the PA CAT, which is like sort of a new thing. And then some of them require the Casper exam. And then some of them need 2,000 patient care hours. And then some of them require 1,000 patient care hours. And some have no requirement on patient care hours. So it's very variable. There's 300 PA programs. It's very variable from one to the other. Standardized tests, experience, GPAs, all the yada, yada, yada. Yes, we have our averages, but that to me has made this application process so complex for PAs, which is why people like me do this. And then between nurse practitioner, it's a little bit more straightforward. They do have their own set of prerequisites. Usually you don't have to take a standardized test. Some of them may require that, but usually it's more straightforward in classes that you've already taken, especially if you're a nursing major. You've likely taken, a lot of those classes. The GPA requirement is a little bit lower. And so some of the programs vary on what they require as well. And so there are a lot of different nursing programs. So there's sort of a BSN to MSN program. There is a, FNP program. There's a direct entry MSN program where you go from, you can apply without a nursing degree. And in that time, you get a nursing degree and a master's degree to become an NP. So there's a lot of different things on that end as well, where I feel like the medical school application is more standardized, so I feel like PAs is the most variable of the three.
Mm-hmm. Yeah, thank you so much for your detailed responses. I think that they're answering quite a few questions we have here, and we have a lot of questions coming in. Another question we have is about shadowing. So obviously with the pandemic, whether you're going for a doctor, a PA, or an NP, it's going to be difficult to get shadowing. But specifically for PAs, are there any tips you have for finding those in-person shadowing hours?
The best thing you can do is network. So I don't care if your sister's brother's cousin knows a PA, you need to get that person's number and not be shy about it. So that's number one. Number two is join your state PA organization if they allow you to do so. Sometimes they have right on their websites people's email addresses. So if you belong to the South Carolina Academy of PAs, or the Florida Academy of PAs, some of them have actual pre-PA sections on their websites. So you definitely want to join your state PA organization, learn about it, learn about networking. Some of them have local dinners and things like that. I mean, I know it's pandemic time, but some of them do virtual things. So go to those things, network, and try to find yourself some PAs. I would say that's a good resource to do that. Social media is a great resource to do that. I had somebody fly here to shadow me for a couple of days last week. That's a good resource for it, which didn't exist before. If you're working in a clinical setting, asking around where you work is like one of the top things you can do as well. So that's kind of where I would be. And then the other thing I would say is you cannot be afraid to ask. The worst thing that they can say is no. So some people are like, how can I ask? Or I don't care if you're a patient. If you're a patient and you're being treated by a PA and you want to go to PA school, you ask that PA, like, hey, I want to be a PA too. Can I shadow you sometime? I've had a ton of people do that. So it's worth, and most people will be receptive.
More about your career with being a PA. How long did it take to feel comfortable practicing, even though you have less guidance from the physicians in your practice?
Yeah, so I mean, I would say 6 months before you feel like, okay, you got your footing, a year before you're like, okay, I'm okay. Now, because I've been doing this for so long, I have a lot of autonomy, and my doctors really trust me. But it also really depends on your relationship with your physicians and how that's cultivated over the time you've been there. Because I mean, they really don't question a lot of things that I do. And they know me that if I ask them, it's because it's a problem. So like usually I will handle most of the things on my own, but if I'm like, I don't know what the F is going on here, they know if I reach out to them, it's because I'm worried, or I'm concerned. And that's the kind of relationship you want to have, where you guys are always in collaboration, you trust each other. They're not questioning every single thing that I do. They're never seeing every patient that I see. They're not, redoing my work. They let me be very independent, but they know that if I'm reaching out to them, it's an issue. We need to figure out what's going on with this patient.
About managing to switch specialties as a PA, how do you do that? And specifically for internal medicine to heme onc, how did that go? Was there a lot of training in between?
So no, internal medicine to heme onc was a bit of an easier switch because there is a lot of internal medicine in heme onc. So I think that the thing that you get more comfortable with over time is yes, your medical knowledge, but it's also your ability to recognize when things are not right and your ability to take care of patients. So for me, like when I transitioned from internal medicine to oncology, I had been taking care of patients for 1.5 years. So I felt very comfortable talking to patients. I felt very comfortable looking up things. So even if I didn't know what the heck was going on, or maybe I couldn't counsel them about their chemo drug or anything like that, I could have a conversation with them. And I would be, I would say, hey, I'm going to go look this up. I'm going to do this. I'm going to come back. I'm going to take care of you, just reassurance that you will figure it out. And that is the piece that you get most comfortable with. So like, even if I transitioned into dermatology tomorrow, even though I wouldn't know all the treatments for every skin condition, I can talk to a patient and I can make them, I know when something's not right. I can recognize when there's emergencies, and just that level of comfort is actually kind of nice because you can always learn something. You can always learn, look up, like use your resources, ask your nurses, ask your doctors. That's what they're there for. But with that being said, there should always be an onboarding time for you when you change jobs. So your onboarding should be 3 months at least. And so most employers will know that and, put in that process of onboarding so that you're training and you're shadowing with other PAs and doctors and things like that before you're sort of thrown into everything.
One student asks about a specific postbac program, but really just in general about postbac programs. So they found a postbac at George Washington University. It's a pre-PA program that's 1 year long, and it covers the prereqs towards PA school, also possibly shadowing several PAs. And there's a certificate to go along with that. So there's resources there, it seems. But in general with postbacs, they're asking and wondering about, is it worth the time, or is it just better off to take the prereqs at a community college?
I think if you have the option to do a postbac like that, I would do it. So if you're somebody that is, okay, so there's kind of different scenarios here. If you're somebody that has decided late in the game, so let's say you're about to graduate or you've graduated or you're, whatever, and you're like, I'm basically changing my whole trajectory and I have to go take all these classes that I didn't take before and try to get into PA school, doing something like that postbac PA program is amazing, right? Because that will take care of all of that for you. You don't have to figure it out yourself and piecemeal it together, but it's expensive. And, you have to think, okay, how much is it going to cost if I go back and do it myself versus how much am I going to do for this postbac program? So cost is huge. Second is, what does your GPA look like and what have you already taken? Because if you're somebody that was on a science trajectory and just kind of struggled there for a little while and then have sort of bounced back, but you need to get your GPA up, maybe you don't need a post-bac program. Maybe you just need to take some a la carte classes to get your GPA where it needs to be. Or maybe you have to retake some of those classes that you didn't do so hot in before because they were prerequisites. So that's a different situation. And then I run into people who have taken all their prereqs and they've done pretty well, but their GPA is still on the lower side. And that's where people start asking me about master's programs. And that's where maybe doing a master's program might work out for you. So the number one thing I would look at is cost. I hate to say that, but number one thing I would look at would be, what is your cost and where are you? So if you're somebody that needs to retake everything, or you're somebody that needs to take everything because you're starting all over, maybe the cost of doing a post-bac might be worth it because you have to start over and it's 1 year. If you're somebody that is having a lower GPA problem, you might not have to do a post-bac. It depends where you are there. Maybe you can just retake stuff at community college, or maybe you can take a bunch of stuff at community college, save yourself for some money, and you know, get a patient care job and kind of do it that way. So it's very dependent on the person, their situation, their personal situation. I mean, you know, so I can't recommend a post-bac program for everyone because not everybody can do that. And it's not right for everybody. But if it's something that seems right for you, then of course that's going to be good.
I think we'll have one last question to end the session off. Another student asks, I feel my friendships are struggling in my personal life as I start making strides with my education and career goals. You mentioned earlier, as your friends graduated and continued moving forward, you were taking classes again. So how do you keep those friendships, and how do you, what advice do you have on this topic?
That's an excellent question, because a lot of people, including your family, are not going to understand what you're doing. They're not. Even when you're in PA school, they're going to be like, why can't you just come out with us? Why can't you just, and honestly, like for me, my answer to them was, you know, I have this goal and I will do whatever I have to do to make this goal. And that means, and I was very upfront with them, very upfront, and be like, I love you. Like, you're always going to be my friend. And I like could use you more than ever right now, but you know, I'm not going to be able to always go. I'm not going to be able to go out every Friday and Saturday night. Like, I totally want to hang out with you anytime that I can, but I can't do all the things because this is really important to me, really important to me. And I was very, very clear, you know, with them that I loved them, but this was very important to me in my future. And they were my friends. Like, they got it. They're like, we know you're not gonna be able to do the things. We're going to be disappointed. We're going to miss you, but eventually you are going to be able to do all the things. On the other hand, it's very important for you to balance that out, right? So you can't be always in the books. You can't be always in that space either. You do have to make time for yourself to enjoy your friends, to say yes, you know, every now and then. You can't say yes all the time, but you can say yes once a month. You can say yes every, you know, couple of times. And so just being really honest, really open. I mean, even with Dave, like when we were dating, I'm like, dude, like, you know, we weren't married when he was in medical school and I was in PA school, and we lived 2.5 hours away. I'm like, I'm not driving there this week. Like, I love you, but like, I'm not driving there because I have all this to do. And so, you know, just planning it out, being proactive, understanding that you are going to miss things, but it's so limited in the big scheme of your life that, you know, it's just a couple of years that you may miss a couple things, and the reward on the back end is going to allow you to even spend more time with the people you love. So I would just kind of focus it there.
All right, I think that was a great ending to our session today. that will wrap it up for us. Thank you so much, Michele, for taking your time out of your
You're
busy schedule.
welcome.
to join
Thank
us
you.
today. Yep.
And
For our
anybody that
audience-
wants to email me, I see some people like emailing me or saying emails. You can certainly send me an email. It's theposhpa@michelleneskey.com.
Sounds good. For our audience, to receive a certificate for this session, you must pass the quiz on our website, which is now uploaded. And be sure to join us next week for our virtual shouting session with Dr. Wachter on August 18th at 7 p.m. Central. And once again, thank you, Michele, for your time. Have a great night, everyone.
Thank you.